Picture this. It's 6 a.m. on a foggy Tuesday. A rancher in mud-splattered boots is leaning on the locked door of a rural clinic. Behind that door sits a perfectly good radiation machine. The problem? It doesn't turn on for another 4 hours, and the machine that's actually closest to his home is 50 miles in the other direction. His surgery went well, but his cancer isn't waiting around. Right now, the calendar, not the tumor, is deciding whether he makes the 5-year survival stats. Here's the thing. Some delays jump out at us. A snowstorm shuts the highway. A linear accelerator breaks. A clinic closes early. Those are easy to spot. The tougher delays are baked into the way we organize care. Who lives near a specialist? Whose chart lands on a tumor board? Whose insurance card needs 3 extra signatures? In rural America, treatment often feels less like a straight interstate and more like a maze of gravel roads, each owned by a different system that rarely compares maps. Today we're going to pinpoint the biggest choke points for head and neck cancer patients in those towns. First, we'll walk through the journey before the diagnosis even lands. Then we'll hit the mileage problem, the specialist shortage, the missing tumor boards, and the insurance drag. Finally, we'll talk fixes, real ones that have already moved the needle. Stick with me, because every minute we shave off this timeline can literally save a life. Section 1. The slow boil before diagnosis. A nagging sore throat, a mouth ulcer that just won't quit. Easy to shrug off, right? In many small communities, that shrug lasts weeks or months. The local clinic might try an antibiotic and say, "Come back if it's still there." Referrals crawl because offices are still faxing forms. Imaging? It's done on the one CT scanner that covers 3 counties, so next week slides to next month. By the time a biopsy confirms cancer, the window for timely treatment is already half closed. Section 2. The 50-mile rule. The Dartmouth data put hard numbers on what rural clinicians have felt for years. Once surgery is over, geography starts rewriting the care plan. When radiation is more than 50 miles away, an appointment isn't a quick visit, it's an all-day expedition. That distance has to compete with calf branding season, frozen roads, and whether the family truck will even make the trip. For many folks, the simplest workaround is to push the start date just a bit. Those small delays add up fast. Section 3. Specialist scarcity. Now layer on the ENT shortage. Counties with fewer otolaryngologists aren't just slower to see patients, they're slower to flag which post-op cases can't wait. Routine follow-ups blur with urgent ones, and the squeaky wheel gets the slot. But calling every day takes time, phone minutes, and confidence, a trio not everyone has. Section 4. The missing tumor board. Think of a multidisciplinary tumor board as air traffic control. Surgeons, radiation oncologists, medical oncologists, and nurses line up what has to happen, in what order, and by when. Without that weekly huddle, people work in silos. A surgeon clears the patient on Monday, assuming radiation starts Tuesday. The radiation team, staring at a full calendar, quietly books the next open slot, which lands outside the 6-week target before anyone notices. Section 5. Insurance friction. Insurance status weaves through every step like burrs on a hiking sock. Medicaid, no coverage, or high-deductible plans trigger prior authorizations, network checks, and financial screenings. Staff who are already stretched batch paperwork so one missing signature can stall a whole chart for days. Let that sink in. None of these barriers are about the medicine itself. They're about the system wrapped around the medicine. Section 6. What's actually working? Here's the hopeful part. Targeted tweaks really do slice the waiting time. 3 standout fixes. Patient navigators who track key dates and pre-schedule the first radiation consult before the patient even leaves the hospital. Tele-oncology visits that let planning happen while the patient is still home, feed in hand, chores done. Modest travel stipends, sometimes just a gas card, that turn "I can't afford the trip" into "I'll be there Tuesday." When programs stacked these 3 moves, start dates shifted back inside that 6-week window far more often. Micro-stories from the charts. A few ordinary details caused the biggest slip-ups. A surgeon's follow-up scheduled on the only day the county bus doesn't run. A planning CT slotted for 7 a.m. while the caregiver works the milking shift. Consent forms written in legalese that make patients nod politely instead of ask questions. None of these show up as medical delays, but each nudges treatment past the deadline. Programs that literally asked, "What does a Tuesday look like for you?" Adjusted clinic hours, bundled visits, or used local labs. The medicine stayed the same, the schedule wrapped around real life. Looking ahead, engineering timeliness on purpose. Imagine real-time tracking built into every rural chart. When a key milestone drifts, the system pings the team, like a GPS rerouting around traffic. Tie that alert to social work support, local housing options, maybe even employer outreach, and suddenly we have a safety net instead of a scatterplot. Outside medicine, there are models worth stealing. Rail-style timetables that flag late segments. Farm co-op sharing of specialist time across counties. A buddy system that pairs recent survivors with new patients for day-to-day problem solving. When rural teams co-design these tools, timeliness stops being a lucky break and starts being engineered. Call to action. 3 questions for this week. If your neighbor developed a persistent mouth sore tomorrow, exactly where would they go first, and how long until someone could biopsy it? Looking at local clinics and dentists, who could you call, by name, to create a faster referral path? Maybe it's a direct ENT line, a tele-oncology slot, or a priority imaging day. Whose voice is missing? Patients who delayed care, family caregivers, community health workers, tribal leaders. Pick one and schedule a 15-minute conversation this week so their reality shapes your solution. Recap: what we've covered today. So here's what we walked through. First, delays start early, long before the specialist visit. Second, the 50-mile gap, specialist shortages, and absent tumor boards pile extra days on the clock. Third, insurance paperwork quietly gums up the works even more. Fourth, small but targeted fixes, navigators, tele-oncology, and travel stipends have already proven they can pull patients back inside the life-saving 6-week window. And finally, designing for real Tuesday morning lives, not idealized spreadsheets, is the secret sauce that keeps timelines on track. You now have a roadmap. Use it. Ask the hard questions, pilot the small fixes, and make sure the calendar never outruns the cure. Thanks for listening, and keep fighting for timely care, because every day still matters.